So should we get cracking, Rick? Okay. Yep. So welcome to the latest COVID-19 Journal Club. For those of you who've not been here before, then I'll tell you a little bit about it. Essentially, there is so much going on in the world of COVID-19 at the moment that the whole idea of evidence and papers coming out is fantastic. But this is a time when we really need critical appraisal. We really need to have a look at the quality of the papers, because it seems that, gosh, pretty much anything can get published at the moment. So we need to remain that sort of skeptical person who was really looking for whether or not these are practice changing and what we can understand. It's also an incredibly exciting time to be in evidence-based medicine because it's happening right in front of us. There's never been a time like this in my lifetime, and probably not for the next century, where we'll see science happening right in front of us and be part of it. And that's really exciting, although also terrifying. So we've got about an hour on the webinar today. And we've got some regular members of the panel. So if you can see them, I'll get them to wave. So we've got Rick Body, Professor of Emergency Medicine, Paul Klapper, Professor of Virology, Charlie Reynard, all-round superstar, and I can't remember his exact title, but I'll come back to it. Dan Horner, Professor of Emergency Medicine, and Pam Vallely, who's also Professor of Virology. And we may get Ellie Hothersall later. Now, the person you may not recognize, but you should, is Lauren Westafer, who's joining us from Massachusetts. She's one of the leading lights in FOAMed education. She runs a huge podcast and critical appraisal site and educational site in the US, which we've been following for years. Lauren, we met many years ago. You're a great friend, and just tell us a little bit about what you've been up to.
Sure. I'm an emergency doc in the United States and also a junior researcher studying knowledge translation, how to get people to translate evidence into practice. And COVID-19 is a great, great venue for that. I also have a podcast, as you mentioned, Foamcast, where we do things from critical appraisal to core content emergency medicine.
Yeah, I just highlight the core content is particularly good. If you're a trainee, it's definitely worth them getting onto that. So that's who's here. Where do we go next? How is this going to run, I think, is where we're going next, isn't it, Rick? So, how can you contribute? There should be a little Q&A thing on the bottom of your screen. If you just hover your mouse down the bottom, it says Q&A or chat. If you bring that up, ideally the Q&A section, we'll be able to answer your questions as we go along. If you can use that, that's brilliant. Anisa Jafar has just joined us as well. So Anisa will wave at us in a second. Another superb researcher, emergency physician here in Manchester. And the topics we're going to cover today are our usual format. We're going to do a deep dive into the effect of non-pharmacological interventions to contain COVID-19 in China. Really interesting paper, which Lauren's going to lead us through. And then we're going to do our usual rapid fire, 5 minutes on a paper, just to bring you some highlights of some really interesting stuff that's going on out there. So without further ado, I think we should get on with the first paper. Lauren.
Great. This paper is the effect of non-pharmaceutical interventions to contain COVID-19, and it's a modeling paper looking at all of the things that they did in China at the outbreak of COVID-19. And as we've kind of learned, these non-pharmaceutical interventions, they contain anything from the least aggressive, which is hand washing your hands, to Rick, can you advance the slides? Sorry. Hand washing, so sort of basic fundamental, we should do that even not in a pandemic, to things like isolation of the ill and quarantine, contact tracing, so figuring out who has been exposed and then quarantining those people. And then of course, travel restrictions, things that more sort of infringe upon people, canceling mass gatherings, even canceling school or work, sort of shutting things down, the lockdown. So these are the various non-pharmaceutical interventions that people are referring to. And if you advance again. And specifically in China, what this paper looked at was they looked at three major things that happen. And the first would be intercity travel restrictions. Traveling between cities, early identification and isolation of the ill. So being able to test people, identify them, and then make sure that they are sort of kept away from the unexposed, and contact restrictions. And that's what we're sort of referring to as social distancing, encouraging people to stay far apart, closing down businesses, mass gatherings, and then just ensuring people don't really have that frequent interaction with each other. So in this paper, they looked at these three specific things. And what they used 3 data sets to pull that together. Now, in China, where this initially started, it kind of coincided with the Chinese New Year, so a major holiday, so lots of travel there. And so they were really interested in the effect of some of these restrictions which imposed travel, and they wanted to kind of get that data about population movement and how people moved. And so they used these data sets from a large wireless carrier, an internet carrier, to kind of track that movement, since at least half the population in China does have smartphones. Not everyone, little kids don't, but a lot of people have those or have used this internet service. And so they used a database to look at smartphone users in and out of 340 cities. And then they also looked back at 2014, 2015, and they looked at what happened during the Chinese New Year, kind of at that time, looked at city level movement during that time, and then county level historical movement. So how were people moving? What was their general travel during those times, to come up with some data about how people migrate or move related to the Chinese New Year, which was sort of a similar time at that time. If you advance again. And the model that they used is called a SEER model, and it's really popular in epidemiology, and especially modeling infectious diseases. Is we want to know what would happen if we did certain things, or where might this outbreak go? And a lot of people are using the SEER model, which it's an acronym for sort of the movement of the population between things. So people are susceptible. They might be infected. They could be infected with COVID-19. And then there's the exposed. They've been exposed to the SARS-CoV-2 virus, or then they've even been infected. And that's the I in the SEER model, or they've recovered. They were infected and now they have convalesced and they're recovered. And a SEER model kind of captures people moving through those states as they are unexposed to completely recovered from it. And in this model, they treated each city as their own subpopulation because, again, they wanted to sort of track movements between them and capture that this really started as a regional outbreak. And they used some conservative assumptions. They did have to make some assumptions, like saying that the median incubation time was 5.2 days, which is relatively standard. And then they used an R0, so the basic reproductive number of 2.2. And this had been estimated to be all kinds of numbers. The most conservative are around 2 to 3. Some estimates, which account for the asymptomatic population or the pre-symptomatic population, even push that up to 10 to 15 without certain restrictions. So here they used sort of conservative assumptions and didn't even factor in the asymptomatic population. And this is sort of what they found, is if social distancing occurred, but intercity travel was not restricted, you can see these curves. So the blue line is the combined interventions, and then the red line is unrestricted intercity travel. And there's not a huge difference between them. And this is just their modeling. And the yellow line, the vertical line in the center, is the start of the lockdown. So you can see the peak happens after that and then falls. So with all the interventions and then with just allowing unrestricted intercity travel, you can see it didn't seem to make much of a difference here. It lowered it some, but not a ton. Go to the next one. Now, without early case reduction and isolation, you see the blue line is the combined interventions. So the early detection and isolation, intercity travel restrictions, contact tracing. The green line is a model or an estimate of what would happen if they hadn't done the early case reduction and isolation. So identifying people who are symptomatic and then moving them to quarantine, and that's quite high. It's estimated that it would be 5-fold higher without the early case reduction and isolation. They looked at what would happen if they waited. So the first thing that they did was they looked at what would happen without these interventions. And had they not done any of the interventions, they estimate there would have been 67-fold higher infections in China. And as I mentioned, without the early detection and contact tracing, it would be 5-fold higher. Intercity travel restrictions, 2.6-fold higher. And then without that intercity travel, it wouldn't have been much changed, so 1-fold. Now, the other question is, what if they'd waited and kind of put it off, because these are impact people fairly majorly. So they say if they would have waited a week, it would have been 66. It would have been threefold higher. 2 weeks, sevenfold higher, and 3 weeks, 18-fold higher. So this is just an example of what would have happened there. This graph just shows if they had unrestricted intercity travel and contact. I think if you go to the next one, I think the header's got a little flipped here. And this shows the delay. So the blue line is the baseline. This is what sort of actually happened, the actual timing of the peak. And if you click through, you'll see these curves. So you can see the peaks had they waited. So again, 18-fold higher if they would have waited 3 weeks. In 2 weeks, it would have been less. And then 1 week, it would have been threefold higher cases is what they estimate. Now, what if they had imposed these restrictions earlier? You know, hindsight is sometimes helpful. So had they imposed those earlier, they would have seen, they estimate 66 fewer cases if they would have done it 1 week earlier, 86%, 2 weeks, and then 3 weeks earlier, 95%. And this is all computer modeling. They made about a bunch of assumptions here to come up with these numbers, but they're estimates to kind of grapple with as we think about many countries, many states within countries or locations are starting to think about how do we emerge from this and which interventions do we drop first? Is it travel? Is it contact tracing? You know, is it early detection and isolation? For example, in the United States, our testing situation is not that great. So maybe we can't drop that one because or we should drop that one, even though it seems to be one of the more effective ones. So this is an interesting paper, I think, because trying to look and see where do you get the most bang for your buck? Where do these interventions, where might they be most effective, and how? Alternatively, what if we, see a second wave start to come up? Which ones might we want to do, and how might we want to act early? I think that a lot of us, initially, it's very inconvenient to have daycares and schools closed, to have places of business. It really has tanked the economy in many places. So acting early, you don't want to act too early, but I think that this is an interesting portrayal of sort of the risk of not acting early or the risk of acting later. So I found this paper interesting from that fold. It is a modeling paper, so taking the exact numbers and saying that you would get 67-fold higher cases from not doing these interventions. I don't think that we truly know that, but I found it was an interesting modeling of these interventions where most papers seem to be treatment papers, and I found this interesting because it's the other things that are going on.
Thanks a lot, Lauren. That is a beautiful explanation of a really complex paper. So if anyone's read that paper, the full text, you'll see that it's actually really difficult to follow. And Lauren, you've really made it clear to us. So thanks for doing that. I just want to point out that we've now got Ellie Hothersall with us, who is an expert in public health from Dundee. So thanks for joining us, Ellie. I know you're extremely busy, so we appreciate you taking the time. This one seems to be right up your street. We'd really appreciate your opinion on what the implications are for public health and how we implement these non-pharmacological interventions at this stage in the pandemic.
Really interesting, isn't it? And I think that the real challenge, and there's been coverage in the local media, at least recently, of a modelling paper that looks a bit similarly, looking forwards and back, to see how many lives could have been saved in Scotland if you'd implemented lockdown measures 2 weeks early. And I think this is the eternal crystal ball gazing that we are going to be seeing for quite some time, where I think there's a bit of an inherent bias in these modelling papers, because they focus on, they're what's the word I'm looking for, they're tethered to the events happening when the events did happen. And so all the modelling is sort of based on the assumption that in some way where it happened was the right thing. if you see what I mean. I think it's incredibly challenging how we define the how we get the population to accept the need for lockdown measures. You just look at the way that the world is responding to them now. You look at parties in England over the weekend, you look at the American responses to lockdown, and you can see that individuals are not massively good at behaving in a way which restricts their liberties if they can't see the damage to or the risk to their health. I mean, frankly, individuals aren't particularly good at behaving in a way that's good for their health at the best of times. And so this is a kind of scaled up version of that. Behavior change is tough at the best of times. Frightening people is a great way to get short-term benefit behavior change, but it doesn't last particularly long. And if we'd frightened people anywhere in the world 2 weeks before we did, would they have actually stayed locked down for any longer? Would the things have happened when we needed them to? Or would we actually just see a different pattern and then some different exciting modelling papers produced about now? And just before I stop, I should just correct the chat thing there. I'm not a professor of anything, sadly. I'm a senior lecturer in medical education, I guess, but I'm a consultant in public health. So half of the time I'm a public health doctor. I'll stop ranting now.
Brilliant, thanks, Ellie. I'll bring in the rest of the panel for some opinion on this paper. So, I mean, loads of topical issues. In the UK, we've just had this announcement from Boris Johnson about a change to the lockdown measures, although it's not really clear that there's too much changed. There may be a big change in the public feeling about the sort of messages that have been sent out. The streets seem to be busier. What do you think we can take from this, and where do we go from here? What does it mean for future waves of the pandemic, and how quickly we might need to react? Pam and Paul particularly might need to come to you on this one for some virology expertise and your expertise.
Well, I was going to ask Ellie and Lauren about what they thought about the Swedish approach to lockdown and this sort of laissez-faire attitude they have in Sweden, and yet their death rate per population is higher than the neighbouring country of Norway, where they have stricter lockdown, and it's the same or not worse than ours. So this sort of runs counter to this modelling that we've got from China. What do they think of that?
So I think that one of the problems with comparing countries is that we aren't all the same. And my understanding is that the Swedish population live in a quite different way. And I wouldn't want, I'm a public health doctor, I'm allowed to make sweeping generalizations, but I wouldn't want to get to the point where I'm making stereotypes. But my understanding is that in general, older people in Sweden live quite distant from their younger members of even their families and so on. So there is more of a, if you like, a kind of social isolation built into the way that they live, plus a kind of philosophical approach to state control, which is probably quite different. I don't know, I don't understand the numbers at that level. When I look at them, sometimes I hear them as being reported as much worse, and sometimes I hear them as being reported as much better, depending on which broadcast you're listening to or which confidential release you've got in your hands. My suspicion is time will tell, which is a rubbish answer when we're stuck in the middle of it. But if part of me, the cold academic, who's quite glad that different countries are doing things different ways, because it means that somewhere down the line, we'll be able to look a little bit more dispassionately at this and be able to see which things were valuable and perhaps why, and things like the modelling paper will help us to disentangle that. But really, we're doing everything at the moment with one hand tied behind our back, aren't we?
I think the other place it'd be interesting to look at is Belarus, which is the country where they've really not decided it's not worth doing anything really. They're still having major sporting events and travel. So I agree with you, Ellie. There's a beautiful natural experiment going on there. Although it's not beautiful, it's terrifying. But you know, we will be able to pull at the end of this some really quite interesting things to look at the validity of the models. The other thing in the models I thought was really interesting, Lauren, is the confidence intervals are huge. So in their models, you know, this is where the line is, but you know, the confidence intervals are absolutely enormous. So and the further you get away from where we are now, so 1, 2, 3, 4, 5, 6 days, it gets bigger and bigger and bigger and much more difficult to predict. So, you know, it is tough.
It was interesting to see that unrestricted travel didn't seem to have that big an impact by itself. And yet that seems to fly in the face of what we saw in, you know, the 1918 pandemic. The big second wave occurred when there was a mass travel, people traveling home from the war and going back to their families. And of course, the outbreak really kicked off after the Chinese New Year in Wuhan. So I was interested to see that because it kind of conflicts with what you might expect.
Yeah, they did have they showed the maps. It's a very technical paper, which is outside of my general wheelhouse. But the maps that they showed of sort of the modeling of the distribution of cases did show an impressive span without the intercity travel restrictions. So it looked like the number of cases wasn't significantly affected, but the more like it sort of stretched across mainland China. And I wonder, you know, this doesn't look at a second wave. So I wonder if some of that would have been, well, those cases might have occurred much later that spread further. And then what happens is you get a larger wave because then those are going out and sort of causing other outbreaks kind of further away. I don't, that's just sheer conjecture based off of trying to make sense of what I saw there.
It's a really good point. You can't have a second wave if the first one is still going. So the peak comes up and goes down again because we've got control measures in place. And actually, if cases continue to rise, you don't get to the point of a second wave because everyone got it the first time around. So that could be one of the, you know, I mean, obviously modeling isn't going to pick up that kind of thing because it's got such a fundamental shift in it anyway. But I think that's also part of the explanation for what's going on there.
Ellie, what do you think are the implications for a second wave? We saw the potential multiplication in the severity of the wave of the pandemic based on the time it takes to react. Does this mean that if there's a signal towards a second wave that we ought to be shutting things down as we go forward?
I'm very glad I'm not a politician because that means I can give my unfettered answer, which is absolutely yes. And that what we should have is a system which is much more alert, much more ready to flip into pandemic mode again, much more quickly. And actually, I would argue we should be able to do that not just for coronavirus and for where we are now, but hopefully our systems stay primed so that when the next flu pandemic comes along, we can do the same thing more easily. But this is about, I guess my worry is that people will start to think of it as being the boy who cried wolf as things go on. But I want to see our systems ready so that we can go into the same kind really quickly if we see cases start to rise again, which is what our politicians tell us they are doing, but we will see how that translates over the next few weeks.
I think that's a really good point, Ellie. And I wonder actually whether we're going to see that put into practice again by the end of this week, because you know the lack of social distancing that was going on in my neighbourhood last Saturday night was huge. Last Friday night was huge. So I just wonder whether we'll, towards the end of this week, we'll actually see a spike again. And you know, what are we going to do? We're just coming out of social, of relaxing some of the rules. Do we go straight back in again? I just, as you say, it's a big experiment.
It is, and I suppose the other thing is that if it doesn't go up after the way that most neighbourhoods I think were the same, although not mine. I live in a very antisocial area, it turns out. But that if despite all that mixing, cases don't rise, then that will be challenging too, because scientists have been saying don't have gatherings, don't get close together. That's where the disease spreads. We actually run the risk of our own credibility being undermined if they don't go up. So part of me almost wants to see a rise in numbers following on from this, because it proves that we've been right up to now. But obviously, I absolutely don't want to see more people getting sick, because I've had it, it's nasty.
Great. Well, that's a really topical issue sorted out for you on the Journal Club. Move on to our rapid fire round, and we're going to go to Dan Horner. We had a paper a couple of weeks ago about the high incidence of venous thromboembolism in patients with COVID-19, and we discussed anticoagulation strategies. Well, this paper might help us to, in a little way, to answer that question about whether we need to give treatment dose anticoagulation. So over to you, Dan.
Thanks, Rick. So a bit more clotology on the Journal Club, which is great. Thanks for giving me opportunity to chat about this one, which I found interesting. So we have talked about the increasing, or the supposed increased incidence of thrombotic events in patients with COVID-19, especially those who are severely ill. But as we discussed a couple of weeks ago, we're getting a lot of observational cohort data through that is just presenting incidence or the findings in different intensive care units. And people are looking for this disease very hard at the moment. So when you look for it, you will find more of it, and it's difficult to get the true incidence of symptomatic events. But this one came to me through a variety of sources, a couple of medical directors in my hospital sending it to me, because the title's quite leading, and then it's been picked up by a number of media outlets to suggest that possibly giving people treatment dose anticoagulation might save lives. So, this is another one that needs full critical appraisal, and we need to be aware of the detail, especially if we're going to believe the title and we're going to change our practice. So what is this as a rapid fire? This is a research letter, is the first thing to note. So this is not really a published manuscript as such. It's a short 3-page summary of some recent work that's been done out of Mount Sinai. Am I pronouncing that right, Lauren? Is that right? But this is a research letter, which is an uncontrolled observational cohort, essentially. And within the Mount Sinai healthcare system in New York, they have introduced an algorithm that seems to lean people slightly towards a lower threshold for empirical treatment dose anticoagulation. If you can move your slide forwards, Rick, I'll just show you their algorithm, which is doing the rounds on the internet at the moment, and highlights an at-risk group where they seem to think that the benefits of treatment dose anticoagulation outweigh the risks, even if you haven't got a diagnosis of VTE. So they are doing it a reasonable amount. And I think the authors rightly wanted to publish the sort of early findings from their data set as to what kind of differential morbidity and mortality they were finding. So in this research letter, they present 2,773 hospitalized patients with lab-confirmed COVID-19. And they break them down into those patients who received treatment dose anticoagulation, which was 786, versus those patients who didn't receive treatment dose anticoagulation, which is 1,987. And they present mortality rates that are essentially the same between those two groups. So 22.5% in the anticoagulated group and 22.8% in the non-anticoagulated group. And we don't know what the non-anticoagulated group were getting in terms of prophylaxis or mechanical prophylaxis. There's no detail in the paper to attest the baseline characteristics for those groups. And there's no real reporting on what usual care comprised, because it's a short research letter. They also talk about bleeding in that population. So into just over 2,500 patients, they saw bleeding rates in anticoagulated patients of 3%, which is higher than you would expect, and major bleeding rates in non-anticoagulated patients of 1.9%, which is again a bit higher than you would expect if those patients were just receiving prophylactic dose anticoagulation. So that's interesting. What they then do is they take a subgroup of the 2,500 patients that were mechanically ventilated. So that's 395 patients in total. And they split them into the group that got anticoagulation, 234, so about 2/3. And the group that didn't get any anticoagulation, who were mechanically ventilated, that's 161. And there's quite a big difference in the percentage of mortality between those two groups. So 29.1% mortality in those patients mechanically ventilated who were anticoagulated versus 62.7% in those who didn't receive any anticoagulation. So a doubling of mortality. And, if you were going to talk about absolute risk, then, a 30% increase, which is huge, isn't it? Of course. They talk about bleeding in that group, but they only present a single bleeding percentage for the whole group of mechanically ventilated patients. So you can't really tell whether the anticoagulated patients bled more than the non-anticoagulated. I mean, the assumption is that they would do, but we haven't got that data in the letter. And their major bleeding rate was 7.5%. So that's high. You know, that's over 3 times what you would expect in terms of major bleeding outcomes for critically ill patients receiving anticoagulation. So high and difficult to explain. In terms of what the authors conclude, they do a good job of highlighting the issues with this paper. You know, they point out it's observational, there's unobserved confounding, there's unknown indications for anticoagulation, there's lack of baseline characteristics, there's possibilities for indication bias. And then they do a Cox proportional hazards analysis to try and look at a hazard ratio for anticoagulation in total. So how does the hazard ratio decrease per day if you're anticoagulated compared to not being anticoagulated? Sorry. And they present a hazard ratio of 0.86 per day, suggesting that you are less at risk of death if you are anticoagulated overall every day for which you are anticoagulated, which is interesting. And they conclude their findings suggest some therapeutic anticoagulation may be associated with improved outcomes. But there is some critical appraisal to do here, isn't there? So, you know, this is very much their presentation of a select bit of detail from their real world cohort, and it's very difficult to know what was happening to these patients. So we don't really know, as I was saying, in the non-anticoagulated group, who was getting thromboprophylaxis, both mechanically and pharmacologically. We haven't got any baseline data to know who was in which group. We don't know who was excluded. So you would kind of assume, I would think, that people being admitted to intensive care in Mount Sinai with clinicians following this algorithm, if they didn't get anticoagulated, then there's presumably a reason for that. And that's presumably because they're a particularly high bleeding risk, or they've got lots of comorbidities, or they've got renal failure, all of which would put them at a higher risk of death immediately. So that's the problem with these kind of uncontrolled observational cohort studies. You're looking at 2 different groups, one of which is anticoagulated and one of which is not, but can you really compare them? You know, they might be very, very different. You know, they tried to account for some covariates in their Cox proportional analysis, but you can't account for unknown confounders, and you can't account for everything. They also don't really tell you within the paper who had ceilings of care in terms of treatment limitations. So perhaps those patients who didn't get anticoagulation were all capped at a ceiling of care because the expectation was that they might not survive, and it seemed mean to therapeutically anticoagulate them and stick needles in them every day. You know, you don't know who was in which group. Perhaps the group who were anticoagulated were patients who were more likely to receive all levels of care because clinicians thought, you know, there was more hope in pursuing treatment. So difficult to know what was going on here, really, and no real data on bleeding risk in addition. I'd come back to the fact that when you look at the kind of raw mortality between the 2 groups, there's no real difference. So 22.5% in the anticoagulated versus 22.8% in the non-anticoagulated. Because of the lack of detail in the letter, it's difficult to know if that's a typo, because that doesn't really look like the Kaplan-Meier curves that they present towards the end of the paper. But you know, their percentage statistics suggest there's no overall benefit to empirical therapeutic anticoagulation in all patients being admitted to hospital. They do present very, very high bleeding rates, and so that's worrying in itself. And then we don't know how long these patients were followed up for. So those high bleeding rates are probably the tip of the iceberg. You know, when we're talking about follow-up in these patients, we should really be looking at least a month, if not 6 weeks, if not 3 months, because when you anticoagulate someone, they tend to stay on anticoagulation for a reasonable period of time, and the longer they stay on it, the higher their bleeding risk goes. So if this is data with limited follow-up, then of course those bleeding risks will be downplayed, but they're already high. It's difficult to know how long they did follow up patients for. So they talk about a 6-week period, a 28-day period between the middle of March and the middle of April. And then the paper goes on to be published in early May, but it's hard to know whether they followed everyone up or not. So, you know, it's an interesting research letter, you know, published in a relatively high impact journal. And I thought it was worth highlighting because it's got a lot of press, and the press is reporting, you know, does treatment dose anticoagulation confer a mortality benefit in COVID-19, especially for the sicker patients? I think we need to be really cautious about that. You know, there's lots of bleeding risk here. This is an uncontrolled observational cohort study with lots of unknown confounders, as the authors point out. And it's difficult to draw firm conclusions without getting any of the real raw data from the research experiment. You know, it's an interesting hypothesis and one that needs to be tested. And I think this paper leaves us with more questions still than answers. You know, does intermediate dose prophylaxis help? Does therapeutic dose anticoagulation help for those who are highest at risk? But I think having read this, I'm still coming back to individualized risk-benefit discussions, really. And whilst there might be some role for empirical therapeutic anticoagulation for patients who are particularly high risk, who you're unable to scan, so you can't really transport them, perhaps because they're on renal replacement circuits or ECMO circuits or CPAP at 80–90% oxygen, and you're worried about transferring them for imaging. Whilst there might be some benefit in that cohort, we still don't really have the evidence to confirm it. So it's always going to be based on the individual assessment of the benefits versus the risks of major bleeding and the concerns of comorbidity. I'll stop there and we'll have maybe a minute for discussion if anyone's got questions or queries.
I just have one comment. I can't help but weigh in on an anticoagulation paper. I found it amazing that they didn't acknowledge the immortal time bias here, where you can't die before, you know, in the anticoagulated group, you are in the unanticoagulated group if you die in those first 2 days. So it took 2 days for people in median to start anticoagulation. And during that time, if you were started on anticoagulation, you were immortal. You had to survive to get it. And so I found that very interesting in this case, that it wasn't addressed, but that is a major thing. When I see this paper, I'm like, that's, I can't really buy the results unless that's addressed.
Yeah, I think that's absolutely right, Lauren. There's also lots of queries about the time of anticoagulation, isn't there? So I think they present a median of 3 days of anticoagulation. So what's that all about? You know, that's not treatment of severe critical illness, is it? A couple of days of anticoagulation just doesn't really make any sense to me. So does that mean that people are changing policy? Does that mean that this algorithm was introduced during this study or this cohort that was studied? Does it mean that different people did different things and you've got outliers, you know, and they're presenting median data with IQR? Really hard to tell within the context of a 2 to 3 page research letter. So how this has got press, I just don't know. And it's a really good example, again, of our thirst for answers, isn't it? And our hunger to do something, you know, well, that's good on Cox proportional analysis. Let's get it out there. But actually, you've got to read the detail and you've got to look for the things that aren't within the paper, and then you've got to ask yourself, wow, you know, is this actual evidence or is this uncontrolled data that needs to be verified?
Yeah, so thanks a lot, Dan. That's a terrific overview. Simon, you wanted to make a quick comment about the level of evidence as well, I think.
You're just so Dan, you're obviously terribly enthusiastic about clots as always, but of all the work you've done and the stuff we've seen about anticoagulation before, this is pretty low on the evidence-based medicine scale, isn't it? So this is a sort of a level 3, I think, type paper, and so it's not normally the sort of level that we would change practice on.
Absolutely. So you'd say probably level 3B, wouldn't you? Or so I would need to bring up Sackett's table of evidence-based medicine to get my B's and C's and A's right. But this is an uncontrolled observational cohort study with significant potential for error, even accounting for the Cox proportional hazards analysis. So yeah, low level of evidence, you know, hypothesis generating, perhaps. That doesn't come across in the title, I don't think, and it certainly doesn't come across in the press release.
So it's something that, like you have had, Dan, the people at the hospital may come to you and ask you about, should we be doing this? But I think the answer is, this is a very low level of evidence. And just like we had with hydroxychloroquine, with those first papers that suggested lots of benefit, we're in the same situation here, that we don't actually know, based on these data, which is the right way to go with regards to therapeutic anticoagulation. Let's move on to a very topical issue again, vaccine development. And Charlie's going to take us through this one.
So Lee et al. Conducted a systematic review of sorts, looking at all the vaccine development going on in the world. They had to look in slightly different spots to where you'd normally look for published papers. They looked in a WHO data set, and they also looked on clinical trials registries. Once they completed that search, they found 115 candidate vaccines being developed around the world, which is a really big number. They found that 78 of those 115 candidates were active, according to freely available data. And of those 78 active vaccines, 5 were in phase 1 clinical trials, which is phenomenal when you think about the timescale for this pandemic. We're 6 months in and we've got 5 phase 1 clinical trials. That's a source of hope. 2 of those vaccines were from the United States, and 3 of them are being developed in China. They're all on a variety of different platforms, from adenovirus vectors that express S proteins to DNA plasmids to artificial antigen presenting cells. So there's a nice heterogeneity there for different platforms that might work better in different populations. Is 5 enough? So Googlis et al. Did a review in the Lancet about vaccine success rates. And to summarize briefly, from preclinical to phase 1 trials, they found that there was about 40 to 57% success rate. From phase 1 to phase 2 clinical trials, they found that there was a 40% to 90% success rate. And from phase 2 trials to implementation, they found that there was a 22 to 79% success rate. So there is quite a big drop off from each phase going forwards. And obviously not all vaccines are developed the same way, and there's lots of caveats with those estimates. The other thing to bear in mind is that they mentioned 5 phase 1 clinical trials there. They missed off the University of Oxford one. It's not entirely clear why, but it highlights that maybe there's more going on that we don't know about, which is reassuring. The picture might be more than 5. And also, since they've published, the Chinese group have registered a phase 2 clinical trial, which is really reassuring. It highlights that they're looking at moving forward. So in summary, this systematic review of vaccines of sorts has found 5 trials that are in phase 1. And also, they've also highlighted that from what was a 10-year development cycle for vaccines, it's getting down to what might be 1 year. Now, there's many a slip between lip and cup, and it might be that some of these vaccines don't work, and that some of the ones that are yet to be in phase 1 are the ones that transpire to be the vaccine that gets us out of this crisis. But this, for me, is a really hopeful and reassuring paper that there is loads of work going on with vaccines, and they are being rapidly developed.
Brilliant summary, Charlie. And we've got a brilliant question here that our panel can get their teeth into here. From Tanya, what would you say to the anti-vax community that vaccines are being rushed through? So we've also got Ellie here. Ellie, would you may want to say something on this?
Okay. Vaccines are being rushed through. The problem is we need vaccines to be rushed through. Vaccine development is not starting in a vacuum. The concepts behind these have been in place for a long time. The principles behind vaccine development and testing are well established and safe. In the grand scheme of things, the number of adverse events associated with vaccines are infinitely smaller than the number of adverse events associated with the diseases that they are there to prevent. And in the case of this particular disease, I cannot see a way that we get a global return to something resembling normal that doesn't have a vaccine as part of that process. However, anti-vaccination propaganda and approaches are based on the fact that people are frightened and that they don't feel that they get enough information about what is there, and about a kind of mistrust of authority more generally. And we are at a time where mistrust of authority is increasing, and things like lockdown don't help that in some ways. So I think we need to be as upfront and honest with people as we possibly can be about this, as with every other vaccine, and we need to be accepting that there are always going to be some people who cannot accept that this is the right way to go forward, and to do what we can to compassionately deal with people who are frightened, and do what we can to not let the conspiracy theorists get too loud.
Just to echo Ellie there, we're going through preclinical trials, phase 1, phase 2. So we're following the normal peacetime procedure for developing vaccines. And moreover, the 5 vaccines that are in phase 1 trials, 4 of them were based on platforms that have been used and developed in peacetime. So there is pre-existing safety data already for 4 of the 5 vaccines we already have.
Just perhaps a word of caution from a virologist, though, because you know, we have seen some bad vaccines coming through previously that have caused a lot of problems. And you know, I think what's going to be really, really important, absolutely, we need to get this, you know, vaccine in place as soon as we possibly can. And you know, the various strategies that are being looked at to produce a vaccine is absolutely right. We need it from lots of different sources, but we need to make sure that we can reassure the public completely that this is going to be a safe vaccine. It's not actually going to cause problems in the people that we give it to at the end, because we have seen, you know, that sort of event previously with vaccines. It's about reassuring as well as and being absolutely certain with the science, I think.
Yeah, I think that's absolutely right. Haunting respiratory virus vaccines is the study that was done against RSV, the 1960s, where they used a formalin-fixed vaccine, gave it to babies, and then the babies had higher death rates and higher hospitalization with serious disease because the vaccine had actually primed the wrong components of the immune system, and it led to immunopathology in these babies who had the pre-primed immune system rather than giving them protection. The other thing about respiratory vaccines is they don't have a good record of prolonged protection following vaccination. So to get it right, and this panoply of new vaccines that are being tried, the great hope is that at least one of them is going to actually overcome these difficulties and be a useful one. So let's hope more of them than normal get through to actual phase 3 study.
Great. So in the interest of time, we better move on quickly, but we do have 2 questions if we could answer them really very, very quickly. What age group will this vaccine help? Children, pregnancy? Is a question from Mard.
So the different vaccines types will hopefully help different subsections on subgroups of society in different ways. Some vaccines are better tolerated and generate a better immune response in different subgroups. So the hope is that if we get more than one candidate vaccine coming through these trials, that we might be able to target it to different groups. And that leads nicely on to another question from Carrie Thomas, which is, are any of these 5 vaccines live? The list of the vaccines is available on the WHO website, but I will just read it off for you very quickly. One is an adenovirus type 5 vector, one is a DNA plasmid vaccine, one is inactivated, another is inactivated, and another is a LNP encapsulated mRNA. So none of them are live.
Right. In the interest of time, we better move on. There's another question from Hitesh. I don't know if anyone's got a chance to type the answer to that one, because we better move on to our next paper if we're going to keep the time. And I'm going to talk about this one. It plays to my interest in diagnostics, and we've got some real experts on the panel that can comment on this as well. So you might have heard about the Abbott antibody test that's been released with a lot of hype, as you might expect, because we all have been needing some good high quality tests to arrive in for SARS-CoV-2. And here we've got a giant in the diagnostic community, Abbott, releasing its IgG test for antibody testing for SARS-CoV. So let's talk about this, an evaluation of that antibody test. What do they do? Well, they've got their antibody test, which runs on an architect analyzer. That's the chemistry analyzer that you'll see in your labs, where you run troponin and other routine assays that you'll have. So if you're in an Abbott site, you already have those analyzers. They took a sort of case control approach to this. So first of all, to assess the specificity of the assay, they took people who they know haven't got COVID, and they knew they didn't have COVID because they were patients who presented before the pandemic. So in 2018-19, they had samples collected apparently for HSV testing, and what was left over they tested for these antibodies. So they don't expect anyone to have SARS-CoV-2 antibodies. And of 1,020 people with 1,020 samples, they found just one false positive. So that gives you a specificity of 99.9%, which sounds pretty good. Then they went on to assess sensitivity. So to do that, they took some patients who they knew had SARS-CoV-2 infection because they had PCR positive samples. So they were patients who were hospitalized with COVID, had residual samples that could be tested for the antibodies. There were 125 patients and 689 samples tested across different days. Now they found that, remember here, that the condition they're trying to diagnose is COVID. So that's the reference standard. And they're assuming that everyone with COVID is going to develop antibodies. And so the sensitivity of this test was 53.1% in patients who were 7 days from symptom onset, not very good. But by day 14, that had risen to 96.9%, and by day 17, it's 100%. So as you'd expect, the sensitivity gets better over time and looks pretty good by the time you get to day 17. So this is why it was well hyped, because those results look so good. Then they went on to do a seroprevalence study in Idaho, where they took 4,856 patients who were just from the community and volunteered to sign up to this seroprevalence study. They tested them for antibodies, and they found that in Idaho, the prevalence of antibodies was 1.79%, which seems quite low. And perhaps the most interesting finding about that is that the highest prevalence of antibodies was in the very old people, over 80, and the lowest prevalence was in children. Just 0.4% of children had the antibodies. So I would critique this by saying it's case control, and that muddies the waters a lot when you're talking about sensitivity and specificity. It's not a good approach to a diagnostic accuracy study. Really, you need to prospectively collect samples from patients who present with suspected COVID, and then you get a much more realistic impression of sensitivity and specificity. But it's the best that we've got quickly. So it's welcome evidence, and it's led to a lot of marketing. So you can book your private test for £60. The question is, should we? I'm looking at Pam and Paul in particular to answer that one.
Well, I love this one. The specificity data is interesting. They use sera that, as you said, they've collected from a previous study, and they represent patients from all across America. And they got very low false positive reactivity rate, which looked good. And then they switched to Boise, Idaho. Now, Lauren, you can correct me if I'm wrong, but I seem to remember that that's on the edge of the prairies, and social distancing is naturally practiced there. So the rate of infection in Idaho is, I think, fairly low anyway. I couldn't understand why a group from Seattle, which is, of course, a very densely populated city, were doing a study in Boise, Idaho. Wouldn't it make more sense to do it with the population in Seattle, where it is spreading and they have got high prevalence of infection? So it was all a bit of a strange study. The actual assay itself, Abbott Diagnostics have a reputation of producing some of the finest immunoassays for hepatitis B, hepatitis C, and HIV, but they do have a slight track record of releasing not so good assays to start with and then refining them. Looking at the antigen that's mentioned in the assay, I haven't actually seen the full details of the assay yet. They're using a nucleocapsid protein, so you'd predict that there would be more cross-reaction with other circulating coronaviruses than one that was perhaps used different antigens. And what I would like to have seen is a study looking at the population pre-December in Seattle, where you would expect coronavirus spread to be greater from the normally circulating coronaviruses. That would give us the true specificity of the assay. And then actually do the study in Seattle, where you've got a lot of infections. So I think it's interesting, but I'd like to see a study from a major city to actually prove that this assay is actually as good as it apparently looks from this paper.
Brilliant. In terms of the what we do and whether you book your private test, I think it seems that this is a matter of curiosity. If you're really curious, you book it, but actually the clinical use case for antibody testing is yet to be defined. So we'll perhaps cover that in a future episode of the Journal Club, because there might be some more evidence in that regard, I hope. But let's move on in the interest of time to screening of asymptomatic health workers at a London hospital. So I think, Pam, you're going to take us through this one.
I am, sorry, just trying to multitask and answer questions at the same time, not doing either very well. Yeah, so this was quite a short paper. It's for a group at UCL and Barts, who set up what they called a COVID sortium. which I think has to win a prize for the worst title of anything. But anyway, which is a bioresource. So they've been collecting specimens, and they're focusing on asymptomatic healthcare workers in London. They recruited 400 participants, got them all to fill in a health questionnaire, and then recruited them to take a nasal swab and a blood sample weekly for a 16-week period. Any patient who became ill, was self-isolating, who went on holiday, or who got redeployed, got excluded and removed from the denominator. So, you know, that they are only looking at patients who are asymptomatic and remain asymptomatic. The rates of infection that they recorded, so beginning on the 23rd of March, the rates of infection in the first week was 7.1% of the population, then 4.9, then 1.5, 1.5, and 1.1. But they lost quite a lot of the, I'm afraid my dog just started barking at this exact moment. They lost quite a lot of the population after the first week. So in the first week, they had 396 people that they got a throat swab from. By week 2, that was down to 284. So they'd lost 112 participants, presumably because they were ill or self-isolating or whatever. And then it was down to 263, and it remained around 267, 269 for the remaining time. So quite a lot of that initial 400 that they recruited were lost. I think this does sort of show that the point they make at the end is that this shows that there's quite a low rate of asymptomatic infection in healthcare workers. And interestingly, none of the patients who were tested positive showed symptoms either before or after the test or reported them. I think the weakness of this paper is that they then compare that with the infection rate in London, the positive test rate in London that Public Health England had supplied the data for. But presumably those people who were tested in the London general population were tested because they were symptomatic, whereas what they're doing here is trying to test patients who are asymptomatic, or healthcare workers who are asymptomatic and who remain asymptomatic. So you're not comparing light with light. What they really should have compared it with is a community population who are also asymptomatic, and then we'd know whether the asymptomatic rate in healthcare workers was the same as it is in the general population. So I don't think it's quite a fair comparison, actually, and it could suggest that, you know, it's still possible that it's slightly higher rate of infection in healthcare workers. But interesting that it sort of coincides with the Office of National Statistics data that came out yesterday, saying that the death rate in healthcare workers isn't higher than it is in the general population either. So I think that, you know, it's potentially positive, but I don't think it was properly controlled. What I would say, though, is that the bioresource that they're collecting as part of this COVID sortium is going to be very valuable, and I'm sure that there's going to be lots of other much more interesting data coming out of it later on.
Great. So I was struck by that low prevalence, Pam, in this study, as you mentioned. Some healthcare workers I know have had some interesting reactions from neighbours and so on who are very scared to go close to them. Does this, you know, perhaps reassure them?
Yeah, I think it would. I mean, I think the rate overall is quite low, and you know, what would be really interesting to know is what is the asymptomatic rate in the whole population. But you know, I think the data that's emerging at the moment is that healthcare workers are not getting much more sick than other people. If you work in a care home, it seems to be a slightly different situation. But for healthcare workers, you know, the neighbours and everybody else should be reassured that they're not posing any greater risk than any of the rest of the population.
Can I offer a bit of a counter thought on this? I think that the fact that we lost, you know, over 100 people between week 1 and week 2 of the study suggests an awful lot of healthcare workers are infected. But those were symptomatic and therefore different. I guess there's a problem that we have no idea at this point whether being PCR positive but asymptomatic means that you are infectious to others or not. And that obviously is one of the great mysteries that we want to know the answer to, and we are far, far too far away from knowing. But I think the other thing about all of this is just that what you're seeing there is that's about asymptomatic carriage in a population who are already also being symptomatic. And so trying to separate those out is the challenge. And then the other bit is how asymptomatic is asymptomatic. So a phrase I have encountered recently, which I found quite helpful, is posse-symptomatic. So actually, if you go back, and other studies have shown, if you go back to people who were allegedly asymptomatic and tell them that they have a positive test and go back through possible symptoms, suddenly they have a bit of a tickly throat, or they have they've been feeling a bit more under the weather. And the retrospective application of that means that the definition of asymptomatic is different. It affects your pre and post test something or other. It's not probability, but it's something else. And again, all of these things I think will come out over time. And doing what you're not meant to do in Journal Club and throwing personal experience into it, I know that suddenly, having had a positive test myself, helped to explain a whole load of little things that I would have otherwise gone to work with. So I think this is really important. I'm not sure it would necessarily reassure me if my next door neighbour was a nurse, or my husband being a GP means that I am less worried about their symptoms or about them giving me the disease than otherwise. But I do understand your point.
Yeah, no, I agree. And I think, one of the things that I think is really interesting is just what a wide variety of symptoms people are, retrospectively reporting once they know that their thing, because some of them are really very atypical to the sort of fever and cough that we started off thinking that this was the typical symptoms for. I think we don't know. There was 112 people lost between week 1 and week 2, and we don't know why they were lost. So I think it's really hard to draw the conclusions that they've really drawn from this paper. But I think what you can say is that of those asymptomatic, of those people that they did screen who were reportedly asymptomatic, the rate of positivity was quite low. I think that's all you can say.
Great. Well, thank you, Pam. Let's move on to our final paper, and Simon's going to take us through this one, which is quite topical again, because we've heard about this being used in the Isle of Man, the app-based contact tracing.
Yeah, I'll be super quick with us. And it's at the Isle of Wight, actually, is where they're doing it. So down south, separated by about 20 minutes from Southampton. So, but it is an isolated place. It'll be interesting to see what happens there. But this is something slightly different. This is a paper looking at the acceptability of app-based contact tracing. I thought the first question I wanted to ask with this one is, the lead author is Altman, but it's not Doug Altman of the famous statistician. I think it might be a relative. But there you go, from Oxford and Germany and Italy and the US. Basically, what they've done in this is gone using a survey methodology, gone out to people and asked them, in essence, would you be prepared to download an app to allow contact tracing? And also, would you be okay about the government or whoever, or Google or Apple, downloading it automatically onto your phone so that we can do the contact tracing? And the idea behind the contact tracing in the apps is essentially your phone will detect whether or not you've been in proximity to somebody else who has tested positive for COVID. So if I test positive for COVID, I tell the app I'm positive for COVID, and then it finds all the phones which I've been near over the last potentially infected period, and they get alerted to either self-isolate or to get tested. Seems like a great idea, and it probably is the only other way, apart from a vaccine, or we just let it run wild, which we're not going to do, of getting out of this mess that we're in at the moment. So what they did is they approached people, and it's interesting to look at how they approach people. Because the problem with surveys is it depends who you ask. Fundamentally, it depends who you ask. If you ask Guardian readers about Brexit, you're going to get a different answer than if you ask the Daily Mail. So the problem with surveys like this, particularly when you deliver them electronically, is it isolates a whole group of people who are interested in doing electronic surveys. And in this case, they used a company called Lucid. Now, Lucid are a commercial organization which have a panel of people internationally, which organizations use as a panelists. So these are, by definition, people who are tech savvy, IT interested, have got time on the time, and like answering questionnaires. So this is not the general population. Now, there are systems within Lucid where they can adjust who they ask, depending on how many people have answered previously. So there is some technological elements to this to try and get what they would describe as a representative sample. But fundamentally, this is not a representative sample. This is not the man on the Clapham omnibus. So what did they find? I'll tell you what they did find. They got quite a high response rate from the survey. This is not surprising because they're using people who like doing surveys. It was about 60%, which is actually not bad for a survey. It's not brilliant, but it's not bad. Primary outcome, would you install it? Yes, 74.8% people would install it, and 67.7% people would accept an auto install. Some differences between countries. The US and Germany were a little bit more skeptical about both of these than some of the other places, and that's fine. And younger people and people who like using their phone a lot were more happy to have this uploaded. So I think this is very interesting. Again, it's a sort of paper which people will use and say, look, we've done evidence. There's papers out there that show that people really want this. You know, 3/4 of people want it. The problem is with any survey paper from a critical appraisal point of view, who did you ask? And in this case, that's quite a select group. So I'm remaining very skeptical here. And I can see Paul nodding furiously in the background there. I think you agree, Paul. Oh, you're on mute there.
I do. One of my queries immediately about the paper was, what is Lucid? How did they select the people? So you've answered that beautifully. The other thing I thought about it was that things move on. And of course, we know more about what's happened in Korea now, where they have used an app to track people. And Singapore's come on stream with their app to track people. So there's a bit more experience. But I'm deeply skeptical that a huge proportion of the population are going to accept another app tracking where they go and what they do, because they do not trust government.
Which goes back to what Ellie was saying before about how we're trying to manage a medical condition, you know, the virus, but it's as much a political problem as it is a medical one in terms of managing this. And I think, you know, my limited access and understanding of public health, it must be an absolutely fascinating time for those of you in virology and public health to look at all of this. It is truly amazing.
I've got a question for Ellie on this one. We heard at the start of this pandemic that, you know, there was a herd immunity issue. If we get 60% of the population infected, then this stops spreading because there's too many people protected that it can't get around. Is it the same with apps? You're not going to expect everybody to use the app, but is there a critical mass of people of users? If you get a certain critical mass using it, that it's going to be an effective public health intervention?
I hadn't really thought of articulating it as a herd immunity equivalent on smartphones, but yes, that's exactly. It's got to be the same kind of principle, isn't it? There's nothing we do where we actually expect to have got full population coverage. But we kind of hope that is enough to create that safety net that catches those who didn't fit into the original.
Actually, in the paper, they did address this.
Exactly it.
So they did address it in the paper. So they estimated that you would need almost exactly the same number. So you'd need 60% of the population to get that. I have not read the detail about how they got to that number, but I thought there was some nice concordance there. So you need to infect as many people with the app as with the virus to get herd immunity, which I think is brilliant.
It's probably based on the same maths, to be honest.
So fantastic. We've had a really nice overview of topics today, and we've run a little bit over time, but it was worth it because we had some fantastic commentary. Thanks to everybody who's joined us, especially our special guests, Lauren, who's joined us despite it being so early in Massachusetts, and Ellie, despite such a busy schedule, for coming and joining us from Dundee, and of course to all our regular panelists as well. So Charlie, as usual, give you a chance just to plug the ARCHEM initiative.
So every week, the ARCHEM COVID CBD team are putting out the top 5 research papers. If you see an interesting paper that you think is worthwhile for emergency medicine clinicians to read, then please submit it through the Google form that's available on Twitter, and we'll put it out to all ED clinicians. Thanks,
Charlie. So we are still planning to have another journal club for the next week. So if you can join us then, same time, that would be fantastic. And we hope to have another great lineup. So thank you all, and we hope to see you then.
Have fun, everybody.
Thanks very much. Bye.